charged surfaces, including the teeth and mucous membranes. Corsadil maintains a significantly lower level of plaque after a professional clean, which helps reduce bleeding gums and inflammation compared to brushing alone. Corsadil is clinically proven maintains a significantly lower level of plaque after 2 weeks, which helps prevent the progression of periodontal disease.
Thank you, colleagues. Welcome to our SADA CPD meeting this evening. I hope you can all hear me well. Tonight's meeting has been sponsored by GSK. Thank you, GSK, for sponsoring the meeting this evening. Before we get going, and while we're still waiting for colleagues to log on, I want to go through just a few housekeeping rules. At the bottom of your screen, you will see the Q&A tab. Please use the Q&A tab to type in your questions, and we'll try and get through them as many of them as we can. If you can avoid using the chat and the other tabs at the bottom, that would be appreciated. CPD certificates for tonight. The meeting carries 1 CEU point. CPD certificates will be loaded to the SADA platform directly, and you can get your CPD certificates via your member profile. If you are not a SADA member, you will be able to create a profile for yourself and access your CPD certificates in that manner. The meeting is also being streamed live on YouTube, so if you're having any difficulty on Zoom, you can always get us on the SADA YouTube channel. There are a few announcements which we will come to later. May I take this opportunity of welcoming you all to the SADA webinar this evening. I will be your host for the evening on behalf of the SADA KZN branch. To that end, I want to take this opportunity of welcoming Dr. Rathiram, who will represent the KZN branch tonight as its branch president. It is an honor to host this meeting tonight, as the topic is one that is not really mainstream, but nevertheless hugely important. Not so much from the technical sophistication of complex procedures, but the impact it has on quality of life. The patients we see, by and large, many of them will have had the diagnosis of oral cancer. It's a life-changing diagnosis. Their world has been in turmoil over the last couple of weeks by the time they present to us. So from a professional point of view, it leaves us in a very, very challenging position. Not only are we there to try and look after this patient in a comforting manner with empathy and so on, we have to then also try and manage the family of these patients. So it's a hugely stressful time for all concerned. So from our point of view of practitioners who see these patients, and sometimes not that often, because we don't see it that often, when we do see a patient to present with some of these problems, we sometimes just forget. So it's such a pleasure to have this topic tonight. On a more personal note, our speaker tonight, Dr. Machirido Motapi Perry, we go back about 20 years, and that's going back to university days. And I had lost touch with her for such a long time. And it was such a pleasure to find out that she's got into maxillofacial prosthodontics, and that's become a big part of her work. So we look forward to her information that she will present to us tonight, and I'm sure we're all going to learn something. Without much further ado, I'm going to hand you to Dr. Rathiram, the KZN branch president, who will introduce our speaker for the evening. Thank you, Dr. Rathiram.
Thank you, Dr. Naidu. Welcome, fellow members, to the start of this week's Post-Women's Day webinar hosted in the warm East Coast shores of KwaZulu-Natal. Tonight, I ensured to adorn a tie being in the presence of our newly elected SADA president, Dr. Ronan Naidu. The KZN SADA family conveys our congratulations to Dr. Naidu and wish you well in your tenure. Keeping with the essence of Women's Month, it is with great delight to present to you a strong, phenomenal female dental professional. Dr. Matsero Motopi Perry attained her Bachelor of Dental Science and Masters of Dentistry at the University of the Witwatersrand. Dr. Motopi Perry is currently the head of department of the Pediatric and Restorative Dentistry in the School of Oral Health Sciences at the University of Witwatersrand, and is also part of the multidisciplinary craniofacial team at the Charlotte Mateke Johannesburg Academic Hospital. Dr. Perry is a known presenter in the field of prosthodontics, both internationally and nationally. Let me not, without further ado, present to you our speaker for tonight, Dr. Matsero Motopi Perry, who will be covering the topic, pre-radiation dental assessment. What is the big deal? Dr. Perry.
Cookie, can you hear us? You need to unmute yourself, please, Cookie. I'm not seeing your screen, Cookie. I think we're getting somewhere now.
Hello?
You can
Good
go
evening,
ahead,
Dr.
Cookie.
Perry.
We can.
Good evening, colleagues. Can you hear me now?
Yes, we can hear
Yes,
you.
go
Wide
ahead.
and clear.
I'm good, I'm good. I hope that this computer won't give me problems. Are you okay, guys?
We
Oh,
are
well,
super.
thank you.
Thank you so much for a very warm and kind welcome. I'm very excited about tonight. I hope that it will be a nice information sharing session. And I'm really looking forward to engaging with colleagues from KZN. And yeah, I mean, as I was busy preparing this presentation during the course of the week, it reminded me of my very, very first presentation, which was really on the national stage. As you can imagine, I was very, very nervous, but at the same time, I was excited. And the presentation was about 9 years ago. It was 2011. It was in Sun City. And of course, it was the big stage. It was the SADA Congress. And it really is an honor for me to be back again and be talking to you guys. You know, the Gauteng people have been speaking to the people from the regions in Gauteng, and I'm very, very excited today. And maybe that's why I'm having challenges, because just like that time in 2011, today as well is my very first one on the Zoom meeting that I am presenting to you guys. So thank you so much for always affording me the opportunity. I'm going to go to the presentation. This presentation, I mean, the pre-radiation dental assessment, it's something that I'm very passionate about as I am in the field of managing head and neck cancer patients. And often at times, even when I am then talking about head and neck cancer, to some extent, one has to speak about radiation therapy, the pre-radiation dental assessment. When Marlies was asking me about the topic. At the time where my head was, that, am I really making a big deal about this? Because at times when we speak to colleagues, especially our medical colleagues, they seem to be asking words to say, is this really a big deal? So I thought, as we're speaking as the dental profession, maybe we need to be honest and look at this and say, in the beginning, a big deal or not. And so I will go into the presentation. Let's see if I can share my screen. And yes, today, so I thought just briefly we'll touch on the head and neck cancer and the radiation therapy, so that it gives us a platform to discuss the pre-radiation dental assessments. And then we'll look at the post-radiation therapy side effects, and then the treatment that one has to do prior to patients receiving radiation treatment, very briefly as well. And then maybe just discuss the challenges that we encounter when we are managing these patients and when we are doing the pre-radiation dental assessment, and then look at the recommendation just to close it up. So when we are discussing the head and neck cancer, I think the one thing that we need to appreciate is the fact that cancers that are in the head region and different areas such as cavity, nasal cavity, the paranasal sinuses, the salivary glands, pharynx, and so on. This by its nature makes cancer be complex, which is something that really makes our lives difficult when we are managing this patient. The other thing that's worrying is the incidence of the head and neck cancer, which is reported that now actually 980,000 cases reported. Majority of these are malignancies of the mucosa, and they are found called the squamous cell carcinomas. And these SCCs are the 6 leading cancers by incidence wide. Majority of these the squamous cell carcinomas, and these SCCs, they are responsible for, and this is the area where we are working, and the area where really we need to be concerned. So when we look at the treatments of the head and neck cancer, we got the surgical sections that patients often go through, and the radiation therapy, which is the one that we will today look at as well, and chemotherapy, which we'll look at briefly. But most of the time, these both treatments are used together in combination. But in addition to that, I normally see that when we speak about treatment of head and neck cancer, the reconstruction and rehabilitation is often left behind. And for me, because when we are managing these patients, I think quality of life is very important. So you cannot really say that we have treated these patients without reconstructing them and rehabilitating them to at least a level where they can have an improved quality of life. Let's look at the radiation therapy. Radiation therapy is a type of cancer treatment that uses the beams of intense energy to kill the cancer cells. It treats the cancer whilst also doing as little harm as possible to the normal tissues. Often it is used in areas that are harder to reach, and at times as well, it's used in conjunction with surgery and chemotherapy, especially in advanced cancers. The types of radiation therapy are external and internal radiation therapy, and they use different types of beams. They use photons, X-rays and gamma rays, particle radiation, electrons, photons, and yes, I can hear you.
Okay. May I interrupt you
for a bit? I can hear you.
I think your internet is very unstable because colleagues are having a problem hearing you. May I ask you to turn off your
Is it problematic?
Feed? Yeah, may I ask you to turn off your video feed, please, and perhaps go back a few slides.
Can you see the slides?
We can see the slides, but we can't hear you so well. It sounds like a very unstable connection. Perhaps if you can turn off your video at the bottom of your screen where it says stop video, but we can still see your slides. That's it, and maybe that'll help us. Try it again, and if you could go back a couple of slides, please. Thank you.
Can you hear me?
We can hear you.
I can't hear anything.
But we're not seeing any slides at the moment.
Yeah, no. I'm gonna start sharing again.
Colleagues, I'm so sorry about the interruption with the
no problem.
Unstable connection.
Yeah. I think today I'm struggling. It's just you least want them. Can you see my slides now?
Yes, we can see your slides and it sounds better. Please go ahead.
Okay, thank you. I was just talking that I used, and in this case, I was talking about the photons, which are using X-ray beams and gamma rays, and also particle radiation, which uses electrons, protons, and neutrons. And different types of radiation therapy, different types of cancers. This, of course, is because of the types, and it's because of the differences in sensitivity to this radiation. This photo that I've got here is just really to show that when you have different, on the right-hand side is the X-rays or the intensity modulated radiation therapy. That's using these different types of, and when you look at the two, you can see that on the X-rays, this patient is going to receive a whole lot of radiation as opposed to when they are using the protons. But at the same time, the decision that the radiation oncologist will do is to choose the type of that cancer will be sensitive to. On the other side is just showing the different dosages that are needed for different types of cancers. The radiation therapy machine, for those who haven't seen it, it looks like a CT scan machine that you can see on the left-hand side. And on the right, the patient is lying and the radiation beam is targeted at that area where the cancer is. What is our role when it comes? The role which today we're going to be concentrating on, of course, is the pre-radiation dental assessment. The other one would be the management of radiation therapy side effects during the reconstruction and the rehabilitation as well is our responsibility. And of course, the most important is the follow-up that we need to do with these patients. The one thing about pre-radiation dental assessment is that it's mostly based on clinical experience. So for those maybe on a more regular basis, you'll be more competent, and maybe once in a while, then you might need to, get a little more experience or discuss with the colleagues when you are managing them or doing pre-radiation dental assessment. There is evidence that's enough to assist us or guide us into making the decision. It's because it's so individualized. Each patient is different. Even if you can get two similar, because of all the other factors that we need to think of, the treatment or the management will be individualized. And also what is most important is that our planning needs to be meticulous. And also we mustn't underestimate the referral systems that we have in place. We need to do this referral systems in a very competent way because we often don't have time when it comes to these patients. So what is important with the pre-radiation dental assessment, I think, is the history taking, the examination, the diagnosis, the treatment and referral, and the follow-up and maintenance of the patients. All these, we are going to do them the same way as we are doing when we are treating our dental patients, but there will be, I won't spend a lot of time, but just to highlight what are the other extra things that we need to be careful about. When you're doing history taking, yes, you're still going to look at your dental history, but it's going to be very important that you assess whether your patient is going to be compliant, to assess if your patient is aware of their oral health and the importance of it. You look at the patient's social history, which will include, is the patient employed? Are they going to be able to come for multiple appointments after the radiation? Are they in a condition where they can manage financially to pay for the dental treatment that you might need to offer them after that? So this is going to make you to be able to make the decisions when you are looking at their medical history is also important, and so is the medication that they are taking. And that's causing xerostomia as an example, because
okay, can I interrupt you for a minute?
Later also causes xerostomia. So if a patient is already, yes, are you still struggling? Oh my gosh.
Okay, we battling with the sound a little bit. I'm not sure
Hello.
where it is, because colleagues all around are finding the audio still quite scratchy. So it's okay for a few minutes, a few bits and pieces in between, and then it cuts off a little bit. So I'm not sure if there's anything Norma can do from her side, in the background to make things a little better, or we just try and battle along.
Unfortunately, doctor, there's nothing I can do. It depends on the doctor's connection.
Somebody,
Maybe
one
she
of
can
the
come out and reconnect. Members are complaining a lot. Somebody was even suggesting that
Yeah.
we should.
But
Maybe Dr. Matsidiso, you can log
I
off
think
and
it was
log
also
on.
low.
I don't know what's happening tonight. I'm really sorry.
Can you hear me now? Because I think my speaker was also low.
We could hear you, but it breaks a lot.
How is it now?
Okay, let's try.
I'm gonna change the
connection.
I'm gonna use a different connection. Should I just go out and then reconnect again?
Let's try with your connection and the new connection. Let's see how it goes. And if we're struggling, you'll disconnect and reconnect. Thank you, doctor.
Yeah.
There was somebody that mentioned, one of the delegates mentioned that it might be a problem with the Zoom servers. So I'm not sure if that's a problem all around. It seems like everybody's having the problem.
Everybody's having a problem.
Patients often take their oral health for granted, not really knowing what's behind the smile. Healthy gingivae are pink and firm and do not bleed on probing or when brushed. But even in a healthy mouth, shortly after brushing, a thin layer forms over the tooth called the pellicle. This layer rapidly accumulates bacteria, which attach to the pellicle and multiply, leading to the formation of plaque. As bacteria continue to multiply, they start to release toxins that can inflame and damage the surrounding gingival tissue. The body responds by increasing blood flow to the area. Increased blood flow and inflammation can cause the gingivae to bleed when probed or even when brushed. If left untreated, symptoms can progressively worsen and may lead to gum recession, periodontitis, and eventually tooth loss. Corsadil intensive treatment mouthwash containing chlorhexidine digluconate is a short-term intensive treatment for patients with gingivitis. Used as an adjunct to professional treatment and advice, Corsadil works by antimicrobial action in two ways: killing the bacteria that cause plaque in 30 seconds by disrupting the lipid layer of the cell walls, causing the cytoplasm to leak from the cell, and by forming a protective antibacterial layer on the teeth and gums for up to 12 hours, as chlorhexidine binds to negatively charged surfaces, including the teeth and mucous membranes. Corsadil maintains a significantly lower level of plaque after a professional clean, which helps reduce bleeding gums and inflammation compared to brushing alone. Corsadil is clinically proven to improve patients' periodontal health after 2 weeks, which helps prevent the progression of periodontal disease.
Let's try one more time, Dr. Matsidiso.
Hello?
Go ahead, Doc, we can hear you.
Okay, let me try again. Sorry, guys. Seems like this is going to be a very long night with the pre-radiation.
Perhaps the pre-radiation interfered with the internet connection. But I believe the entire day today there's been an internet connection issue. Myself, I've also experienced that throughout the day today.
Yeah, because I've also changed the connection. And I hope that this one will be better.
Okay, let's continue.
Sounds better already.
Can I start from here? Where do you think I must start from? Is this slide fine?
Go back a slide.
Back another slide. That's one.
Yes, please. Yeah, I think we can.
Okay.
Yeah.
Thank you. Go ahead.
Okay. Okay. Thank you so much. Apologies, colleagues, for all these problems. I hope that we'll get it better this time around. When I was on this slide, I was just talking about the radiation therapy and just showing you how the machine, some of the machines looks like. And I was saying that this one looks more like the CT scan machine, for, which is the one that we are mostly, most of us know. And on the right-hand side, you can see a patient lying, and the radiation beam is directed to the area where there is cancer. It's targeted at that area. And then I said the role of us in managing radiation therapy patients is what we are discussing today, the pre-radiation dental assessments, and then it's also the treatment of those patients before they get radiation, and the management of the radiation therapy side effects. Also, we will reconstruct and rehabilitate these patients, and then followed by the very long maintenance and follow-ups. The other thing is that most of the time, the experience, clinical experience of the clinician is what is guiding the decisions that they're going to be making. Because yes, we do have some evidence that's out there, but most of the time, because the treatment and the management is so individualized, it requires us to really, really have the experience in doing this assessment. What is therefore important is that we need to do a meticulous planning and proper referrals amongst us and medical colleagues and everybody else who is involved in this patient, managing this patient. So when we look at the pre-radiation dental assessment, we have to do the following: our normal history taking, which we are doing when we are seeing our dental patients, examination, diagnosis, treatment, and follow-ups. But there are certain things that we will have to do in addition to the normal way that we normally see our patients. When we are doing history taking, yes, we're going to look at the dental history of the patient, which is very important, the social history of the patient, because we need to understand, is this patient going to be compliant? Is this patient aware of their oral health? And are they willing to make sure that they keep their side of keeping a very good oral health post-radiation. Is the patient employed? Are they going to be able to come for our treatment? Are they even going to be able to manage some of the dental treatment that we are going to be doing for them in the future? And of course, we also look at the medical history and the medication that the patients are also taking and how they're going to influence the patient's outcome. But in addition to our normal history taking, now we need to look at the radiation history. We need to know what radiation doses are these patients going to get? What are the radiation fields, the sizes of the fractions, the types of the ionizing radiation that the patient is getting, and when is this patient even going to start radiation? I'm not going to go into detail about this because this is a whole topic on its own. And I think it is better when you are discussing it with people who are seeing majority of pre-radiation dental assessments or managing head and neck cancer patients. For today, I just want us to be aware that there is much more that we need to know when we are doing pre-radiation dental assessments. We need to know that if a radiation oncologist says to you as a dental practitioner, this patient is going to get 60 grays of radiation. They are receiving intensity modulated radiation therapy, and their radiation is going to be given in this type of fractions. It has to have a meaning to us. So I think a take-home message for us in this case will be to say that there is a lot that we need to learn regarding radiation if we are going to be involved in the pre-radiation dental assessment. Just an example here. Here are the two modes of radiation therapy. The one is the conventional radiation therapy. The other one is the intensity modulated radiation therapy. As you can see on the right-hand side, that the area that is going to be radiated is much smaller compared to when you are using the CRT. So if I am assessing a patient and this patient is going to get a CRT, my approach is going to be much more radical than looking at a patient that is going to receive IMRT. Because with IMRT, it means I might save some of the teeth on the left-hand side as opposed to on the CRT. So this knowledge of the different types of radiation is going to assist me in making those types of decisions. What we had done when I was still in charge of the maxillofacial prosthetics, which now Dr. Chukwani is, we came with this forum, which is a communication tool between ourselves and our medical colleagues. And the intention was to make sure that we get the information that we need. In addition to the patient's contact details, we're also looking at the current medication that the patient is taking, the diagnosis and the staging of the cancer. We were looking at, is this patient receiving radiation or not? If they are, what is the dosage that they're going to be getting? Are they receiving chemotherapy? If they are, what are the drugs that they're going to be receiving? The surgery, are they going to have a surgical resection? When is the operation? And we also give just a little bit of space so that the surgeon can also give us information about that. Is this patient going to get palliation? If they are, additional notes so that we understand the extent of the palliation. We also had this sort of drawings for our surgeons so that they can show us where are the margins for their surgical resections. I might be looking at the tooth and thinking that I need to restore this tooth and I need to do 1, 2, 3. Meanwhile, my surgeon is going to resect that tooth together with the lesion. So we need to know this information. I suggest that for those people who are communicating with their other colleagues, you can come up with sort of this kind of tool, and it can have the information that you require. In terms of examination, I'm not going to go deep into it because this is the examination that you are doing when you are doing your extensive examination for your patients in your dental setting. My diagnostics, requires your radiographs, your models, and your photographs. But the one diagnostic tool that we are often not using in our setting is the oral microbiology tests. And in this case, the salivary flow rate and the buffering capacity. This is very important so that we can get the baseline of where our patients are. Because later on, when they have challenges with the salivary flow and buffering capacities, we can know where they came from. And also when if we're starting on a bad footing, then we know that this patient is going to have more problems, and therefore we can plan for that. You can treat the patient at the time after your examination, do your scale and polish restorations, extractions, and if you need to refer, you can also refer at this stage. We also need to discuss with our patients the orofacial radiation therapy side effects. This is very important. The radiation oncologists often give them a global view of what they're going to be going through, but they are not going to give them information as you would do, because for you, xerostomia is very important for your treatment. Is very important. When it comes to trismus, it's very important. So all those things for you, it's going to be important that you discuss them with the patient. Is this patient going to get post-rehabilitation? Explain to them when are they going to get it, what type of prosthesis are you looking at, so that they also have an idea of what is going to happen. I've just put a few cases just to show you that some of the reasonings that one would use when you are doing the assessment. In this case, this one is pretty obvious, a patient with periodontal disease. And as you can see, quite a big bone loss around those teeth. And therefore, for me, this one calls for a radical approach. The literature also shows us that if you don't do this, you are setting yourself up for a lot of problems. Spear-Hasey in 2011 found that the patients that had pockets of more than 6 millimeters, 19% of them ended up with osteoradionecrosis. The patients that presented prior to radiation with period disease, 33% of them got osteoradionecrosis. So when I see a patient like this already in my head, before I even look at other factors, the radiation factors, the social factors, already I am thinking of doing a very radical approach. And in this case, we did the complete dentectomy for this patient. And what is important, as you can see there on the picture, is that when you're doing extractions on these patients, they have to be as atraumatic as possible. And it is also advisable to also suture so that we can facilitate quicker healing. A patient like this, multiple restorations which are already failing. When I look at this patient, I can already see that this patient is very susceptible to caries. Even though at the time when they could afford to go to the dentist, they went and they took care of their teeth, but almost the whole mouth ended up with restorations. Therefore, just like the previous case, it also calls for me to think of a radical approach. Of course, I will look at where the cancer is, where the radiation beam is going to be, but I'm most likely going to extract this patient's teeth. A patient like this, on the other hand, a much younger patient, much better dentition, I'm most likely already leaning towards conservative treatment. I'm definitely going to look at the compliance of the patient. I'm going to look at where the cancer is, where the radiation is going to be, but I'm going to try by all means to save this patient's teeth. In the cases where I need to extract, it might just be the teeth that are in the line of the radiation, and if it's a very high dose of radiation. I have written unerupted or impacted 8, and it's not necessarily for this patient because this one, as we can see that the patient's still growing, those teeth are still growing. So I'm just saying that even if it was a 35-year-old, a 50-year-old with unerupted or impacted teeth, the main thing that we have to look at here is there communication between the impacted tooth and the oral cavity or not? If there's communication, the literature tells us that it's better to go and take out that tooth. If there isn't any communication and everything is okay, there's no inflammation around that tooth, then leave it alone. This patient, what I just wanted to show was that when you have a patient like this, which has a cancer lesion as this one, and there's teeth in that lesion, we know that those teeth are going to be resected together with the cancer lesion. So you're not going to start wanting to go extract those teeth. You can also plan the other extractions, and all of them can be done in theater when the patient goes for a surgical resection. Unless you have time and you want to do extractions on the other quadrants and you want those to heal. But in general, this patient, most of the work can be done in theater. Unless there are also some areas where you want to do restoration, maybe on the 3rd quadrant, there's a tooth that you want to do a restoration, that's what you can do. If possible, you can also do your scale and polish clean if the patient is able to cope with that. Other patients, on the other hand, might be receiving palliative treatment. For me, this is where I become a little bit confused at times, because with palliation, my mind tells me that I want to make the patients as comfortable as possible for the remaining time of their lives. But at the same time, I'm just thinking that I also don't want to leave teeth in the mouth, which will make their last days also to be miserable. So there's always that catch-22 situation. One is saying, should I be extracting the teeth or maybe just imagine that the patient is just comfortable, and it's something that you will have to assess. If the patient has a good set of teeth and you think that you can manage, you can give them fluoride rinses just to keep them as strong as possible for the remaining time that they have, then do so. But if you think that there are teeth that are carriers and they need to come out, or it's the periodontally involved teeth as we've seen on the other patient, I would rather also extract those. But as I said at the beginning, palliative the patients are the ones that, for me, I always find myself, not really knowing which direction to go. At times you get it right when you see the patient. At times you say, oh, maybe I should have. So let's look at the post-treatment side effects of cancer in general. These patients often get resections, and today the one important for us is the radiation side effects, and briefly we'll look at the chemotherapy side effects as well, and even the reconstruction, which we think is improving the quality of life of patients as I said. Sometimes it can give us some of the very unpleasant outcome, as we can see this flap on this patient. So when we're looking at some of the post-radiation therapy side effects, radiation includes caries, mucositis, dermatitis, xerostomia, trismus, autotaste, and most importantly, radionecrosis. I'm going to quickly just go through necrosis. It is defined as the exposed bone within the radiation treatment volume that persists for 3 months or longer. It's more in the mandible than in the maxilla, and the risk increases if radiotherapy is given together with chemotherapy. The contributing factors, if patients, the extractions are done patients after radiation, if patients have pedral infections, and even the denture trauma can also lead to this osteoradionecrosis. This is just one of the patients here with post-radiation therapy side effects, as we can see, not present at all, ulcerations, mucositis, infections, and trismus. It's very difficult for these patients, really. The other patient, which is also quite upsetting because this patient was in a private setting and he was given radiation and pre-dental assessment was not done. And this led to patients having radiation-induced caries. As you can see with the trismus there, me and you can put 3 fingers minimum in our mouths, and this patient could hardly even push 1 finger into their mouth. And worst of all, the patient ended up with osteoradionecrosis. And as we can see, this is really not a pleasant sight at all. And the patient ended up with a pathological fracture, which we can see on the mandible on the left-hand side. This is just one of those cases that when you hear people saying that osteoradionecrosis, the incidence is very low. If you see this one patient, it's enough for you to understand what it means really to manage this patient or to even be in the shoes of this patient. This is another patient with osteoradionecrosis who also ended up having that pathological fracture as well on the right-hand side. As briefly, chemotherapy, it also has side effects that are similar to radiation therapy, but in addition to that, it has also oral hemorrhages, neurological changes, and also what is called bisphosphonate-related osteonecrosis of the jaw, or now it's medical-related osteonecrosis of the jaw. The side effects when it's chemoradiotherapy are quite increased, and the incidence of osteoradionecrosis is also increased. And in this case, you might find the patient having spontaneous ORN. No extraction, no infection or nothing, but they just end up with this radionecrosis. Just briefly, the treatment, we prefer that emergency dental treatment is done for these patients, especially when you are looking at patients with periodontal diseases, caries, and fractured patients, and so on. These are the treatment that you need to do as possible. And also, one has to look that they are in the line of the high dose radiation field, especially if they have, even if they can have just a minor dental disease and they are unopposed by other teeth, this might just call for them to be extracted. So majority of the times, the treatment that we are doing for these patients is extractions, restorations, and root canal treatments only if the teeth are really going to be having like the best prognosis post-radiation. Scale and polish and oral health education is so important because you want to maximize the health of these patients prior to them even going for radiation. The extraction protocols often you get the questions where clinicians are asking, when do I extract and when don't I extract? Unfortunately, there are very few clinical outcome studies that guide the clinician. The decisions, as I had said already, they are tailored for individual patients, and they're taking into account patient factors, radiation delivery factors, and concomitant chemotherapy, just amongst others. Dental treatment ideally should be completed 10 to 14 days prior to radiation therapy. A lot of people are also saying between 14 to 21 days. I think by just understanding the nature of the environment that we are working in, that we don't have that much time. If possible, yes, you can longer. But if you can complete dental treatment 10 to 14 days before the date that the patient is going to receive radiation, that would be better. Okay. You give your patient follow-up appointments so that when they're on radiation, they also come to you for further management. And then you refer them back to the radiation oncologist. Management, I'm not going to go through it, but I was just wanted to highlight that this is our area as well. We are the ones that have to manage these patients. Carious lesions, we have to manage them. We have to manage the trismus, mucositis, and everything else that the patient is going to present with. So most of the time, I ask my patients that when they're coming for the radiation, the time that they're going for their radiation, they must also just via the clinic so that I can see how they are and I can also help them to manage the effects. For instance, when you're looking at trismus, it's going to be very difficult to treat the patient after if they cannot really open their mouth. So you don't want them to be in a situation where it's so bad that they can't even open their mouth. So you start to give them exercises to do to help them to keep the opening in a better situation or level. I just wanted to show with this patient that yes, they might come the way that they are, but at the end of the day, after they have healed, after you've managed them properly, they can actually be in this situation like this patient. Post-radiation, at times there's a need for patients to have extractions to be done. And that's something that is not ideal, but we find ourselves having to do it. And when one has to do these extractions, we know that that we are predisposed this patient to osteoradionecrosis. And in the literature, there are certain people who have recommended of hyperbaric oxygen. There's some who are saying that it's not working, but there are also the evidence that it's working. And together with vitamin E and pentoxylin, it's found to work much better if the patient is to get actions. In the cases where the patients need dentures after radiation, you've got to make sure that those patients know and are aware that it will take about 6 to 12 months before they can get the denture, because we know that the denture will predispose them as well to osteoradionecrosis. So avoiding anything that can cause an ulceration, anything that will cause an irritation in their mouth until after that period of time. The challenges that we encounter in this field, these patients are managed by a multidisciplinary team. And unfortunately, we know majority of us are so used to working in silos, working in our little spaces, that we end up having a lot of communication problems, a lot of misunderstandings. But what is even more is the egos that we all come with. You know, I am the prosthetist, so I'm better than you. I'm a surgeon, so I'm saving the patient's life. And I think this is really our biggest challenge that we are seeing. Often there's not enough time as well to proper dental assessment and treatment before radiation therapy. And that is because these patients are sent to us just a few days before they get radiation therapy. Even though they have done, they've waited for months before they've waited for blood tests and all those things done. But when they come into us, it's when it's already too late. And to understand urgency, because you can also even see the extent of the cancer that they are having. But I think it's just a matter of proper planning that we should be included right at the beginning as well. Our problem is that even ourselves in our settings, we don't have protocols. If we have protocols, they are not even that ideal to manage these patients. Our referral systems are often not really good. When we are referring to each other, the forms are incomplete, if there are any, and this causes really delays in what we are doing. Delays in treatment, maybe if you are a practitioner in your practice is much better, but in our setting where we have different departments and the patient has to go to this section to go and do extractions and somebody else has to do restorations, and it becomes a big problem in managing the patients. There's a big delay in this treatment, which then reduces that time that we have, which I said can be between 10 and 14 days. I think the most worrying one from my side is that the involvement from the health team is very poor, especially from the general dental practitioners. Often specialists will be involved because there's treatment that they might need to do. Either the surgical resection or maxillofacial surgeons are involved. From the pro side of things, I'll be involved with the surgical obturators and other specialists as well. Periodontists will also be involved. So in a way, the specialists sort of find themselves having to be involved, but our general dental practitioners, who are really the people that I think should be in the forefront of this, often they are not really involved. And at times it might just be that the teams are not opening up these opportunities for them to be part of them. I think that the solutions to all those challenges is that we need to put systems in place, the protocols, the systems. We need to communicate better. We need to be able to treatment plan together, to share information about the patients. And this is really the teamwork that is required. But I think the most important one is also understanding that our patients are the priority number one. And nobody else is as important as our patients. When I look at the head and neck cancer team, I think this team have almost everyone from the general practitioners, dental practitioners, to the family of the patients. They are the ones who live also with the patient. We mustn't leave them behind. The social workers. So this team is quite an extensive team, and we need to make sure that do not forget that the most important member of this team is our patient. So in instances where we are confused about what needs to be done, we have to say what would be the best thing for our patient, and we'll never get it wrong. If we forget about the patient, we will do whatever that we think is good for us, and then the patient is the one who's eventually going to suffer. So then this is where I was asking that, what is the big deal? Really, in the bigger scheme of things, when I'm thinking that pre-dental assessment is all about this one tooth, one has to ask themselves that, are we really making noise where it's not necessary? But having worked in this environment, I think I have learned that the big deal is that these small things matter so much in life. And that is because they can end up causing all these big problems. So I've learned to respect that and understand that, yes, it's a big deal for me because we are dealing with the cancers that the incidence is high, there is morbidity and mortality that's involved. There's these side effects that patients will eventually go through by virtue of receiving treatment. So if I am saying that it's not a big deal, then I don't know what a big deal is. At times in the team, I do feel like a tooth fairy, which is good for me. But inside, I know that yes, I'm kind of a big deal of a tooth fairy. And my main thing is I'm a big deal because I improve the patient's quality of life. And that's all that I'm thinking about. And I think this is our role as dentists, this is our role as dental specialists to make sure that all that we're thinking about is to improve the patient's quality of life. Yes, at times it might be overwhelming when we think about management of patients, but at the end of the day, the challenges and the difficulties that we come across, if these difficulties are going to benefit our patients, it becomes a very satisfying job indeed. I think that was the last slide, and I would like to acknowledge the teams from the West Oral Health Center and the teams from the Charlotte Maxeke Johannesburg Academic Hospital, which I'm working with these patients, and the implant clinic as well in our institution, and most importantly, the maxillofacial prosthodontics clinic team, which is still welcoming me even if I'm no longer in that department. But most importantly, I'd like to really pay a tribute to our patients who are allowing us to be on this journey with them as they are going through these very difficulties and putting their trust and hope in what we are doing. And colleagues, with those challenges that we've had at the beginning, I would like to say that if we can just find ourselves in the service of others, as what Mahatma Gandhi said, I think we will be able to say that we are doing service to our patients, and we can go to sleep, I think, peacefully. With those few words, I'd like to say, thank you very much. Once again, apologies for all the glitches that we had. Thank you.
Thank you, Cookie, for that challenging lecture. I know it was tough with the sound not coming across that well, but we braved it and we got through it. So thank you again for just hanging in there and for your lecture. We've got a few questions. If I can start off, and if I'm missing any, Ratiram can come in and have a look. The first question says, is our approach the same for patients receiving radiation, for example, breast cancer or stomach cancer?
Okay.
That's it.
You want me to answer as we go along?
Yes, please.
The approach is not the same because in this case, the radiation is in this area where we are working in. And therefore, one is really looking at the damage that's going to be done by those beams of radiation. The patients that are receiving breast cancer and colon cancer will come to us, and mainly that would be also because they'll be receiving chemotherapy. The we are still expected to do thorough pre-dental assessment, but your decisions will be much better will be different from when they're receiving radiation as well in the head and neck region. You will, in this case, maybe look at those teeth that are not in such a good condition, the teeth with huge carious lesions, the teeth that have periodontal disease, those ones that are obviously and definitely needs you to address them. Unlike with the head and neck cancer, where at times even teeth that are not necessarily having dental disease, those teeth might have to go just by the virtue of them being in the line of the radiation beam. So that would be the difference. You'll still be expected to do your thorough examination and your assessment, but your decisions will be different.
Thank you.
Thank you. I hope I've answered that.
I think that's quite clear. Let's go to the next one. It says, what is the recommended healing time following extractions prior to beginning radiation therapy to avoid possible osteoradionecrosis? I think you did cover this perhaps, but perhaps you can give it another go.
Yes, I'd said that a time between 10 to 14 days is what is the minimum time. Other colleagues prefer much more, between 14 to 21 days. But like I said, often at times when these patients are coming, we don't have the pleasure of having time. So the more time, the better. But between 10 to 14, you're still okay.
Thank you. There's Alfred Easton. Hi, Alfred. How is osteoradionecrosis of the mandible managed?
It depends on the extent. If it's still at the beginning, they can often debride. They can debride the area and then give a patient antibiotics. This is the aspects that are managing these patients. But in certain instances, the resection even of the mandible is required. As you have seen that today, I've shown the worst cases. So it really ranges from conservative to more extensive, depending on the extent of the osteoradionecrosis. I might have answered it briefly, but I'm sure our maxillofacial surgeons would go deeper into that. But that's mainly the basic way that they're managing it.
Fair enough. Thank you. There's another question. How do you manage trismus in a patient post-surgical hemisection prior to radiation or during the radiation treatment process? So essentially, how do you manage trismus?
Okay. Trismus, especially if it is prior, we try the most conventional way. At times, I give patients the sticks, the spatulas that they can actually just keep on increasing them to open. Even their fingers, at times I just tell them to keep on putting few fingers. They practice when they're at home so that the muscles and the ligaments don't get stiff. There are other professional, I think, gadgets that are used. And also this is where, as we spoke about the team, the role of the team, the physiotherapist also becomes involved as well. So these patients are also refer them to the physiotherapist. We've just also been fortunate to have a physiotherapist who comes to see our patients once a week. And these are the patients that they will also see to assist so that they don't get to a point where trismus is worse.
Thank you. Another question. How long after radiation can extractions be done?
After?
Yes.
So, Doc, how long after the radiation?
After radiation, can extractions be done?
Ideally, we don't want to do extractions after radiation, which is the challenge that we are facing, because we know that extractions after radiation are predisposing patients to osteoradionecrosis. So definitely, one would prefer to have those extractions done before, but in cases where extractions needs to be done, you know, if a patient is in that much pain, that's what's going to guide you, you know. You can't say to a patient, okay, let's hold on for another 2 weeks or whatever. If it's an emergency, the extractions that are done are extractions that requires emergency treatment.
Thank you. There's another question that says, after how long can extractions be done? Sorry, after how long can extractions be safely done on a patient who has been on chemotherapy involving bisphosphonates?
I think it's also the same thing. It's also the same thing that you do them because it's emergencies. You know, there's no necessarily a safe period because it's also the same thing. You don't really want to do extractions after these cases. At any point that you are doing extractions, we've got evidence that even after the patients have stopped taking bisphosphonates, they can still be predisposed to getting the branch.
All right, so we have another question. What oral rinses do you advise for children with leukemia?
I would not necessarily say that there's rinses for specific patients with specific cancers, especially when it comes to children. It depends what the rinses are for. You know, it really depends what the rinses are for. So in this case, there's nothing really that specific.
Okay. There's thank you for a lecture, for a good lecture. And then there's a question. Is there a service available for head and neck physiotherapy that patients can access post-surgery and during radiation therapy as a means to prevent or treat trismus?
Yes, I mean, in our setting, honestly, for me to set up the team when I was beginning to be in charge of the head of the maxillofacial prosthodontics clinic, I had to run around. I had to put down, after I read that the team requires to have these kind of people, and also because of what I needed. So I went to the physiotherapy department and I spoke to them. And then after that, I had somebody that was allocated to come and see my patients. I mean, the similar thing with the psychologists, that these patients are going through so much. And I had to go to the psychology department and say, I've got this type of patients and this is what they are going through. Please, can you join me in assisting these patients? So I think wherever you are, one will need to find out where the physiotherapy, either department, if you are in a hospital setting, if you are in private as well, to see which colleagues are around you, the physiotherapists that your patient can access, and speak to them. And these are the services that from my side, I had to set up. I had to go find the people. Because at the end of the day, there was nothing that was in place at the time.
Thank you for that. Yeah, it is indeed a challenge to try and get these patients coordinated, because there's so many practitioners coming together during a stressful time for the patient. There's another question that says, do you need to do pre-radiation dental assessment for patients that receive radiation treatment to the parotid gland?
Can you please repeat that, Doc?
Do you need to do pre-radiation dental assessment for patients that receive radiation treatment to the parotid gland?
Definitely, definitely. Those are the ones that we really, really want, because that's what's going to affect our saliva. And this is what's eventually going to cause those radiation-induced caries because of the poor saliva in the patient's mouth and the changes in the consistency of the saliva. So these are actually the top in a priority of patients that needs to have pre-radiation dental assessment.
Thank you. Thank you again for the webinar. What are the types of salivary substitutes for xerostomia?
There's different ones. Honestly, I'm not necessarily telling my patients to get a specific one, but as long as, especially those ones who are affected quite badly, any saliva substitute is working. I mean, normally when we travel overseas, there's always better ones that, you get a sample and a patient says this worked very well, but then we cannot access them. So whatever that patients can get, I always just recommend that they must just get something that will help them with the saliva.
Thank you for that. Another question, how long after radiation therapy can root canal treatments be done?
Root canal treatments, I think they can be done, especially if you are avoiding the extractions. That can be done as soon as you see that the patient needs root canal treatment. Yeah, we often just do them. There's patients that are coming to us, which are coming from radiation, and they've already done radiation, and pre-radiation dental assessment was not done. So when they present with conditions that would require us to do root canal treatment, we do it immediately. You don't waste time because you don't want the situation to be worse.
Okay. Another question, what is your treatment for post-radiation xerostomia?
For xerostomia, first of all, I always like to start simple. I tell my patients to carry a bottle of water, just keep on sipping. And one can use the Silagox, one can use the saliva substitutes. So there is anything and everything that can help with increasing the saliva in the patient's mouth that is appreciated. But it just depends on the extent.
Fair enough. There's a compliment here for interesting content. Another question, what are the precautions taken for pregnant women after or during radiation?
To be honest, as we all know, radiation and pregnancy, I don't think that I haven't actually even seen a patient who's pregnant receiving radiation therapy. And probably maybe this is just one of the contraindications, because these patients might be receiving other types of radiation and treatment, and maybe radiation therapy is postponed until at a later stage. I would want to believe that the radiation oncologists will avoid that by all means. But if they have to do it, there's always precautions of putting the leather aprons around them, or even the planning. I'm sure the type of radiation that's chosen, the shielding, even around the head and neck to try and protect scatter radiation. So I'm sure there is a lot that the radiation oncologist will do, and the team that side. I know that their planning is quite extensive. with the radiographers that are working there, the radiation oncologists, their nurses. There's quite a big planning that takes place before patients receive radiation therapy.
Okay, thank you for that. There's a question regarding the use of a diode laser. Can the use of a diode laser assist with trismus in cancer patients?
Yes, I mean, trismus is trismus. So I do believe that if it can assist, I'm sure it can be one of the tools that we can use. In our setting, we are not necessarily using it for that, but I want to believe that it does have space in that.
All right. There's a subsequent question, which I think you've covered already, but I'll read it anyway. Is there a salivary substitute on the market that you can recommend for patients with severe xerostomia? I think you have covered that. I don't think there's much to add unless you want to say something more.
No, thanks, Doc.
Okay. Should patients who have already had radiotherapy and or chemotherapy and who require extractions rather be referred to a maxillofacial to reduce the chance of osteoradionecrosis?
In our setting in the hospital where we do have our maxillofacial colleagues, all of my extractions are done by the maxillofacial surgeons. But like I said, that if you are going to be doing those extractions, they are not really any special kind of extractions, because I believe that any general dental practitioner can do that. You just have to do them as atraumatic as possible. And if possible, you need to suture so that we can facilitate a quicker healing. But if you prefer, you can send them to your maxillofacial surgeon. But honestly, it's something that can be managed by any dentist.
Thank you. There's also another note of thank you and a question that goes with it. How do you plan for prosthetic rehabilitation where the patient has to undergo jaw resection, stroke pre-surgical impression and modeling or post-surgical? I think it's quite a tough question.
Yeah.
Do you want me to read it again?
No, it's fine. That's another topic for another day. I think Dr. Naidu promised to invite me to KZN once the lockdown is finished, and I promise to cover this extensively. I've got nice presentations that covers that. That's a lecture on its own. It needs you to go through all the stages. That big defect that you saw there, we take impressions of those. You go through the whole process. And at the end, you have to decide whether you're going to rehabilitate conventionally or with implant-supported prosthesis. So it's quite an extensive procedure and process, I mean, that one has to follow. But I promise that one day I'll cover that.
Thank you. There's a further question. Do these patients have high morbidity rates? Do they have high recovery rates?
It depends really on different factors. It depends on the type of cancer that the patient has. It depends on the patient factors, as we spoke. You know, other patients might have other comorbidities. It depends on the radiation that they would have received, the type of treatment, either it's radiation and chemo. So there's many factors that one will have to think about if we have to answer that question. But we know that the head and neck cancers, they have high morbidity and also mortality rate. So we are dealing with patients that at times we see patients and they don't make it, and some patients do really do very well under the conditions. And yes, I mean, we're seeing the in between, if I have to use our clinic as a as a setting to answer this question.
All right. There's one more question that I'm seeing. Can an endophile that goes past the apex cause a problem post-radiation therapy?
If there's no infection in that periapical region, it shouldn't. But if there is any infection, then definitely it will cause problems. And these are some of the things that when you are doing your pre-radiation assessment, you look at that tooth and you say, is this tooth having the potential to cause problems in the future? If you have doubt and you're saying, I might end up having a periapical lesion around this tooth, then it has to go. But if it's already post-radiation and you have that tooth that wasn't extracted with the file that's extending and there's no infection, then you need not worry. You just have to keep a close eye on the tooth.
Thank you for that. I think we've pretty much got through all of the questions that I'm seeing, unless I've missed something out. And if Dr. Rathiram wants to maybe ask those questions. If not, I will hand over to Dr. Rathiram.
Fortunately,
you,
Dr. Naidu, you've covered all the questions that have been asked. I don't see any further questions for tonight. I must say thank you to Dr. Piri for a very informative lecture, something that's really important in the general practice of dentistry. What I can take home from this lecture is that a holistic approach to oral healthcare is rather important, and communication is key. The small things that we do will add up and make a huge difference. And I really do agree with that comment that you've made. I must also thank our members for attending this evening's webinar. And thank you guys for your patience during the beginning of our webinar, where we had an impromptu supper intermission. I do remember at one of our KZN events where I addressed our fellow members as being dental superheroes. And I think that resonates now more than ever. And I thank you, fellow members, for going out there and maintaining the oral healthcare of the community during this trying period in healthcare. And I thank you all for continuing to strive. Dr. Piri, thank you once again for a rather informative lecture. And thank you to GSK for ensuring that this event goes on. And to all the guys behind the scenes, Noma and our unspoken hero, Marlies, who has been working tirelessly, making sure that these webinars are a success. Thank you, Marlies, for your efforts. It's greatly appreciated. And thank you, Mr. President, Dr. Naidu, for availing yourself tonight. KZN is really honored to have you in their presence. I wish all members a good night and God bless, and have a restful evening.
Thank you so much.
Pleasure. Before we round up, a reminder, on the 13th, we've got Northwest Branch. It's their turn to host a webinar, and they're going to talk about understanding the TMJ. And on the 18th of this month, you've got Bordekai Branch, occlusion in implantology. So look out for those two. You'll get the reminders. You can register accordingly. I think we all know the drill now. And from SADA side, apologies again for the choppy start to this lecture, but I think it all turned out good eventually and got better and better as the talk went on. But thank you so much for attending. The numbers were great, and we look forward to seeing you again shortly. Thank you and good night, everybody.
Thank you. Good night.
Thank you. Good night.
At GSK Consumer Healthcare, One of our core values is to put our healthcare partners and their patients first. Since the start of COVID-19, we have been working around the clock to ensure that you, as our trusted healthcare partner, and your patients remain our number one priority. GSK has created a Dentistry Mini Atlas app that enables you to view chapters, select articles, edit images, save images, or print for use as a poster or patient information leaflets. It's a dentistry compilation of resources at your fingertips. Some of the modules included are anatomy, physiology, pathologies, and our GSK product information. The Dentistry Mini Atlas app is available to download from the Google Play Store and Apple App Store and through the Sensodyne website. After downloading, look out for a prompt requiring a username and a password. The username is GSK and the password Sensodyne. For access to the desktop version, please visit sensodyne.co.za. Click on Dentistry Mini Atlas at the top right of the page and use the same username and password. Look out for an email from SADA. If you need any detailed information, assistance with download, or a user demonstration, please reach out to your GSK dental representative to assist you.
Thank you, everybody.
Thank you, Marilise.
Thank you, Ma'am, please.
Thank you, Doc, and for keeping